Good morning, everyone. After 5 sessions yesterday and the sixth session in the morning, we are starting the seventh session of this 24th IACTACON 2021. And this is a session which is technically supported with the General Electrical's GE company, GE Ultrasound and their subsidiary divisions, GE Healthcare. And to start this session, we have got Dr. Vinayak as moderator. And I request Dr. Vinayak to start the session along with the chairperson and the speakers. Dr. Vinayak, please.
Good morning. And once again, I welcome you to the session 7 of cardiac ultrasounds for this virtual IACTA conference 2021. I will take this opportunity to introduce my 4 chairpersons, and afterward they will introduce the 3 speakers. So Dr. Vishwas Malik from CN Center, All India Institute of Medical Sciences, New Delhi. Then Brigadier Vishal Chaudhary, he is from Cardiothoracic Center, what is popularly known as CTC Pune. Dr. Naman Shastri, who all of you know, he's the Dean ICC, and he's from Epic Hospital, Ahmedabad. And Dr. Chirojit Mukherjee from Helios Heart Care, Karlsruhe in Saudi. So I request the people to introduce the speakers one after the other.
Dr. Venugopal Kulkarni comes from Citizen Specialty Hospital, and he shall be speaking on point of care ultrasound for cardiac anesthesiologist. Now I request Dr. Vishal Chaudhary to introduce the next speaker.
Thank you, Dr. Vishwas Malik. Good morning to you all. It's a privilege to be here amongst you all as chairperson of the session. I introduce Dr. Deepak Bode, who is a consultant in Ozone Anesthesia Group in Aurangabad, and he'll be talking about left atrial strain promising new parameters for left ventricular diastolic dysfunction. Now I request Dr. Naman Shastri to kindly introduce the next speaker. Thank you.
Hello, good morning, everyone. It is a pleasure and honor to be part of this event, and I congratulate entire organizing team for conducting such a beautiful sessions with a beautiful organizations and the great attendance. It's a really pleasure to introduce Dr. Rajninath Karthike. He's the professor and head SRMC Chennai, and he has lot many experience of cardiac anesthesia. And I hope we all enjoy these sessions. And now I just give back give back mic to Dr. Vinayak Desurkar to conduct the sessions. Dr. Vinayak, please.
Vinayak, please unmute yourself.
Thank you, Naman. I request Dr. Venugopal to start his talk, please.
Good morning, everybody. Today, I'll be talking on point of care ultrasound. I thank the organizers for giving me this opportunity. Ultrasound has become ubiquitous, and cardiac anesthetists have played a role in getting ultrasound into anesthesia practice in the form of transthoracic and transesophageal echo. Now, the uses and indications of ultrasound are only widening. It is used in the form of vascular access, for regional blocks, assessment of vascular conduits, airway assessment, lung ultrasound, Doppler documentation of peripheral pulses, gastric ultrasound, diaphragm ultrasound, and focus. As far as vascular access, it can be used for peripheral venous access, central venous access, and arterial line placements, both in plane and off plane. Here I am demonstrating the in plane access of the peripheral vein when it is difficult. We can see both the anterior and the posterior wall of the vein. We can see that the cannula entering into the vein comfortably, then we'll get a flashback. Once we get the flashback, we slide the cannula a bit more inside so that the cannula is within the lumen, and slide the cannula inside. And as far as The central lines axis, we can access subclavian vein, IJV, and the femoral vein. Here I'm demonstrating the IJV. Vein gets compressed, and then we slide it down to see the subclavian artery and then the subclavian vein. Okay. The saline is used as an acoustic coupling gel, and then we use some of the local anesthetic because the patient is awake. Use a proper dose of local anesthetic, and then use the needle so that the needle should be seen in its entire length entering into the vein. A small adjustments will make the needle visualized, and we can see the needle entering into the vein. As soon as the needle enters into the vein, we get a flashback of blood in the cannula, and then the guide wire is inserted. We should see the guide wire direction, where it is going, whether it is going towards the heart or not. Sometimes it can go to the opposite side. Once we confirm this, we can go ahead with our dilatation and placement of the catheter. Similarly, it is used for arterial line placement. Here again, we are using it in line. We can see the cannula coming in. The advantage is that we can see both the anterior and the posterior walls. We can avoid double puncture, and sometimes it can result in arterial aneurysms. So once the artery enters into the cannula enters into the artery, we'll get a flashback, some more advancement, so that we ensure that we are within the lumen, and then slide the cannula in entirety into the artery. See, this is supraclavicular subclavian vein, and it is sitting so nicely on the shoulder so that it will not cause the patient because if you put IJV, it will be hanging around the neck, and then this subclavian vein sits nicely on the shoulder. Coming on to the airway ultrasound, it helps us to locate the cricoid, cartilage, thyroid cartilage, hyoid bones, tracheal rings, and esophagus. And it can be used for cricothyrotomy, for using the cricoid, so the cricoid pressure for RSI, for airway blocks, airway assessment, and percutaneous tracheostomy. Here we can see the longitudinal view of, and then we can see the cricoid cartilages, tracheal rings are seen nicely, the cricothyroid membrane is seen nicely. These can help us to establish the airway access. Here I'm demonstrating the intubation, where if it enters into the esophagus, we can see the double tracking sign and double track sign, and that is sensitivity and specificity of nearly 100 to 100%, so that we can know whether the intubation is done esophageally or not, so that we can avoid these things. Okay. Once we have intubated, we ensure that it is in the trachea, and then the pleura moves, and then we can see these A lines, and these are the B lines. And then if there is movement of the pleura on both sides, we can see the sliding sign both on the left side and right side. Ensure that the tube is in the trachea and not in one of the bronchus. And we can put the M mode, and you can see the seashore sign both on the right side and the left side. Okay. And then pleural effusion, it's helpful in patients like post-operatively. X-ray may miss, but ultrasound is very sensitive in detecting even small amount of pleural fluid, so that we know that whether there is any drainage is required or not. These B lines can be seen whenever there is interstitial disease, or whenever there is fluid overload in the lungs, as in pulmonary edema, especially in these patients who are having heart failure and perioperative goes into pulmonary edema. We can detect them with the more the number of B lines, more severe will be the pulmonary edema. And then this is lung point, and then when the pleura is sliding, we can see that sliding sign, and when there is no pleura underneath, then we can't see the sliding sign. So this is seen in pneumothorax. If there is fluid, it is seen as dark reflection, whereas whereas air is there, then we see all these mm, white shadows beneath the parietal pleura. Visceral pleura has moved far away, and we cannot detect the movement of the visceral pleura against the parietal pleura. So the junction where we can see the visceral pleura against the parietal pleura, and the point where we cannot see anything beyond that is called as a lung point. The farther away from it is more of a pneumothorax. And we can do the diaphragm ultrasound. We can see the thickening of the diaphragm, and then we can see degree. We can, based on the thickening fraction, we can establish the paresis that can occur perioperative. This is not very much. We don't see much of this diaphragmatic paralysis post cardiac surgery, but it is more for critical care. And then specific for cardiac surgery is that we do ultrasound for just before we harvest the veins and the arteries, we see them. So that in one of our patients, we had this plaque in the radial artery, and we avoided taking the radial harvesting. We see the branching of the saphenous veins, so that we know where we can get a good conduits. Gastric ultrasound. Patient is either in supine position or in the right lateral position, and the probe is positioned vertically with the pointer towards the cephalad, and we can see the antrum of the stomach just underneath the liver, beneath the liver and the superior mesenteric artery, and we can establish the area of that. Based on the area, we can estimate the volume, and we can also see whether the contents are like liquid, or they're solid, or the gaseous materials are there. And then if solid is more, then the risk of aspiration is more, and if the volume is more than 1.5 ml per kg, then the risk of aspiration is high. And this especially if we are taking up for emergency surgeries, or even though the patients are fasting for adequate period of time, most of our patients are diabetic, the emptying may not be adequate. And regional blocks are used, like PEX block, SAPB, ESP blocks are used perioperatively, and we are demonstrating one of the ESP blocks that we are using in our patients. It gives a very good pain relief postoperatively for the patient. Initially, we do a midline assessment, and then slightly move the probe laterally so that we see the ribs, and come back to see the transverse process. Give a local anesthesia, and then use the ten-centimeter needle, stimoplex needle, for giving the block. We just have to be just beneath the erector spinae muscle on the transverse process, and this is the ultrasound image of the same thing. We can see the needle coming from this side, and then this is the transverse process. There's a trapezius muscle, rhomboids muscle, and erector spinae, and once it reaches here, like on the transverse process, then I can see the entire needle. And then once we give the aspirate, ensure that there is no blood, and once we give, we can see the spread of the local anesthesia. And erector spinae block is very helpful. It is up to postoperatively, especially when we are fast tracking and extubating the patients very early. It is very helpful for control of postoperative pain. And Foley's catheter, sometimes we have noticed that Foley's bulb will not be able to deflate, and then we do an ultrasound, and then we can actually puncture suprapubically, and then it will be easy to remove them. And this is one more, this is not required, but we just out of interest saw that how our TE probe goes into the stomach. You can see the liver and then the TE probe coming here and entering into the stomach to get our transgastric views. Okay. In one of our patients, post-operatively, the CVP was okay, but the patient is not doing very well, hemodynamically going down. Then we got the patient, put a TE probe, saw that there is a collection. CVP may not really indicate our pericardial tamponade. And then here we can see that just around the right atrium, there's a big clot sitting. As soon as we took the patient back to the theater and then decompressed, there was immediate improvement of the same. And this is one more TE image where we can see that there is a moving block. In these patients, we have to avoid putting IABP and focus like parasternal long axis views, where we can assess the LV function, valve function, mitral valve, aortic valve, and then we can see the ejection fraction, and we can see the aortic valve and LA in the M mode so that we can see whether the LA is dilated or not. And parasternal short axis view, start with the mid papillary view, and then this is apical where we lose the papillary muscles, and then we come back towards where we see these chordae tendineae, that will be the basal. If you move further up, tilt it further upwards, you can see the aortic valve. Tilt it further up, you can see the pulmonary artery. And then this is the four chamber view. All the four chambers are seen, and we can see the mitral valve flow, mitral regurgitation, tricuspid regurgitation, and the TAPSE for assessment of RV function. Slight anterior tilt will open up the aortic valve. We can assess the aortic valve Doppler, and we can see the aortic stenosis and regurgitation. Subcostal view is very helpful perioperatively. If there is any correction, we can use it and then to guide and then see it. Sometimes there can be an AST, which can explain the unexplained desaturation post-operatively. And it is also used to see the great vessels and IVCs to see the volume status, hepatic venous Doppler, and all these things put together will help us clinically to get to a very quick and formidable clinical diagnosis, and we can take a clinical decision quickly and intervene so that the patient does not deteriorate. So we should have very low threshold for use of USG, and USG is a non-invasive and cheapest and portable mode of available for us investigation, and then it has become part of modern anesthesia practice. Thank you once again.
Hello. Yeah, I would like to thank IACTA for giving me this opportunity to present a promising new parameter for LV diastolic dysfunction, that is left atrial strain. So I'll be briefly discussing about what are the unmet needs in the present diastolic dysfunction guidelines, the left atrial mechanics, how we can evaluate that, particularly with LA strain, and how LA strain is useful in left ventricular diastolic dysfunction. We will be talking about some evidences, and we will also quote our own recent study, which is published in JCVA, and some future perspectives. All of us will unanimously agree that diastolic dysfunction is fairly common in cardiac surgery. Almost 1/4 of the patient, they present with advanced diastolic dysfunction, and that can affect the patient adversely in terms of mortality, mechanical ventilation, ICU readmission. And if it is combined particularly with systolic dysfunction, then it is having even more worse outcome in long. So this famous algorithm is from 2016 guidelines. Basically, it has got two algorithms: diastolic dysfunction categorization in normal LVEF and patients with reduced or depressed LVs. So 4 parameters: E prime, E by E prime, TR velocity, and LA volume index are considered. And patients are either having normal or diastolic dysfunction or indeterminate. In patients with depressed LV, we are more interested in knowing whether the patients have got grade 2 or grade 3 diastolic dysfunction, which is associated with increased LA pressure. Looking at this complex algorithm, we know that it is time consuming with multiple parameters and significant number of patients. They are in indeterminate grade. So most importantly, these guidelines are not focused for surgical patients. So there is definitely an unmet need for a single parameter to guide quick assessment of LVDD and LV filling pressures to assist in decision making. So how LA functions, how we can assess that? LA function is basically divided into 3 functions. The reservoir function, which is filling of LA during systole, the pump function, which corresponds with the P wave on the ECG, which is LA contraction, and in between is the conduit function. So these 3 functions can be comprehensively assessed with LA strain. And this paper has very detailed analysis on how we can go ahead with the LA strain. So I'll just quickly share this video of EchoPack, in which LA strain is calculated in a 4-chamber focused view. The endocardial borders are traced. The region of interest is traced with this. The care being taken to avoid the pulmonary veins and LA appendage in a 2-chamber view. The width is reduced, and you get 6 various segments of the LA, and you get a nice positive left atrial strain. We have to remember that most of these softwares actually use left ventricular strain and they extrapolate it. But there are now softwares being developed by Tomtech, and even in GE, some newer machines, they are giving dedicated left atrial strain parameters. So basically, reservoir function is by left atrial strain reservoir and the emptying fraction. Remember, this is not EF, this is emptying fraction. The pump function is assessed by left atrial strain at the P wave, and it is an active emptying fraction, or the strain rate at the A velocity. And the conduit function similarly is assessed by a passive left atrial strain analysis. The normative values for all these parameters in European population has been described in this NOR study. So coming to evidence of left atrial strain for categorization of LV diastolic dysfunction. So this early study by Dr. Roberto M. Lang and his group described that as the diastolic dysfunction, diastolic function from a normal to grade 3 reduced, the left atrial strain simultaneously worsened or reduced. You can very clearly see all the 4 categories here. The same group actually published another very interesting study in which they compared the invasively measured LV-EDP versus left atrial strain. And you can see in this patient with a normal LV-EDP, and all parameters are within normal limit, as comprehensive guideline wise, and the peak LA strain is 41%, which is essentially normal. Compare that with this particular patient who has got a restrictive filling. So this is grade 3 diastolic dysfunction, and obviously patient has got a elevated or a higher EDPs of 19 millimeter of mercury, which correspondingly patient has got peak LA strain of only 6%. So this is grossly reduced. So instead of these multiple parameters or an invasive parameter, you can make out that this patient has got an elevated LVEDP based on a single parameter. Another interesting patient in which the category is indeterminate, because you cannot assess the tricuspid regurgitation, and the E by E prime and LA volume are contradictory to each other. In this particular patient, the LVEDP was only 5, which was essentially normal, and patient had got a normal LA strain. So this resolved a indeterminate grade. So as compared to other conventional parameters of LV-EDP in patients with heart failure, like E by E prime and indexed LA volume, global LA strain performed much better with an area under curve above 0.9. So this means the predictability with global LA strain of a higher LVEDP is much better. And this is true across all the ejection fraction categories as far as the left atrial strain is concerned. But E by E prime failed to correlate in patients with depressed LV ejection fractions. So other components of left atrial strain, we were up till now talking about the reservoir strain, the LASR, which we were talking up till now. But contraction and conduit function also very comprehensively or significantly predicts the LVEDP in patients with normal ejection fractions. This recent paper, very interesting one, monitored the LA strain over admission. At the time of admission, this patient was in frank LV failure with mean pulmonary pressure of 67 and corresponding left atrial strain was only 5%. After a couple of days of decongestion therapy and other modalities, the peak pressures reduced to half, that is 31, and correspondingly, the left atrial strain improved to almost 12%. And at the 6 weeks of follow-up, this left atrial strain improved further to 18%. There is another new index which is being developed, which is called as LA filling index, which is E by LA strain ratio. And if it is above 3.27, then there is very high chance that patient will have a higher LVEDP. So this is very important, important figure in which you can see the LA strain reduces in a linear fashion across the worsening of diastolic dysfunction grades. And you can see the indexed LA volume and E by E prime, they are very late to increase, and they have got sort of a ceiling effect after certain grades. So they cannot pick up patients in early phase of diastolic dysfunction. The E by A actually has got a bimodal presentation. So it can pick up patients in early phase and very late phase, but it can miss patients in between. But in contrast, the LA strain can pick up patients if it reduces in a linear fashion. So it can pick up patients at all grades of diastolic dysfunction. So this LA strain speckle tracking has been used for LA mechanics in general anesthesia, in which they have showed that it doesn't have the effect on atrial contraction. So there is no myocardial depression actually, but only the longitudinal strain reduces. Coming to our recent paper, which I was referring to, we published this in JCVA recently. The LA strain as a single parameter to predict LVDD and elevated LV filling pressures in patients undergoing Ofcom CABG. We studied 60 patients by transthoracic echo. The cardiac anesthesiologist did the echo on a pre-anesthesia checkup, and we found that all components of LA strain, that is reservoir, conduction and contraction, and even the strain rate reduced in a linear fashion as the diastolic dysfunction grade worsened. And this LA strain rate was very significantly associated with elevated LV filling pressures, that is grade 2 or grade 3 diastolic dysfunction, or patients with no diastolic dysfunction versus any diastolic dysfunction grade. And not only that, this LA strain was associated it could predict the high LVFP even in patients with preserved and depressed LV ejection fractions. So this was useful across the board. So coming to this particular patient who had got essentially all the comprehensive parameters suggesting that a normal diastolic dysfunction, normal diastolic function, and his corresponding LA strain rate was 35%, versus this patient who had got significant tricuspid regurgitation, higher LA volumes, and reduced septal and lateral E prime and a higher E by E prime ratio, his corresponding LA strain was reduced to only 17%. So conclusion of our study was this LA strain as a single parameter is significantly associated with grade of LVDD. It decreased significantly with a worsening grade of LVDD. The strain rate, the LA strain rate, LA strain reservoir value below 19 significantly predicted high LV filling pressures, both in patients with preserved and reduced ejection fraction equally well. So definitely with all these evidences which we have discussed, the LA strain will surely find a place in future LVDT guidelines, but unfortunately it has not yet been studied in TE. The main reason being inability to delineate complete LA borders. So as we have seen in the decompensated LV failure patients, probably in perioperative period, various therapies and its effect on LA strain remain to be investigated. So is the effect of various anesthetic medications on LA strain. But if any parameter has to work in long term, it has to show its effect on outcomes. So the outcome studies with the larger number of patients which are prospective enrollment are warranted as far as LA strain is concerned. Thank you.
Good morning all. It's a matter of great pride to be in this virtual natural conference of IACTA. I thank Dr. Thomas Koshi, Dr. Rajesh Arya and Dr. Uday Gandhi for giving me this opportunity. With this short introduction, let us move into the topic of hemodynamic calculation during echocardiogram. One really interesting topic which is very essential for any anesthesiologist who do echocardiogram in the perioperative period. That is nothing but your hemodynamic calculation using echocardiogram. This might look as complex like what you see in the blackboard, but if you understand the physics behind it, it is really and simply very easy. As put by Lord Kelvin, when you calculate something or measure something, and if you are not able to put it in a number, your knowledge is not satisfactory. So for getting this calculation into a number, you have to understand certain physics behind it. The Indian great mathematician, he said like it is magic until you understand, but it is mathematics thereafter. If you understand Doppler, continuity, Bernoulli and get a good image, you can calculate the volume, area, pressure and even assess the LV function. Your understanding of hemodynamics depends upon the physics behind echocardiogram. It all started with the bat. Bat emitted the sound, and from the written sound which comes to the bat exactly knows the distance from which the sound has come. This principle is nothing but sonar, which is nothing but sound amplification and ranging. This technology was used in submarines in 1930 and it was applied in health industry in 1980s. After that, there was no stopping ultrasound in medicine, and now anesthesiologists use ultrasound like a stethoscope. And what is unique about it? It made the physiological, hemodynamic and mechanical measure of cardiac function in a non-invasive way. That is very, very important. Previously, we have to insert a needle or put a catheter into the chamber or into the great vessel to measure the hemodynamics. But Doppler made it non-invasive. You have a Doppler probe with a piezoelectric crystal which emits sound at a particular frequency which is Ft, and this sound hits the blood vessel at a particular velocity which is c. What we are going to calculate is the velocity of the blood flow. This is the calculation which we need, which is nothing but v. And this probe sound hits a blood vessel at a particular angle which is called as incident angle, which is measured as cos theta. And finally, the sound which goes back to the probe, which is nothing but the Doppler shift. If you rearrange this equation, you get the velocity. We have calculated the velocity with the transmitted and the returned frequency. Now look at the flow pattern. There are two types of flow. One is the laminar flow, another is the turbulent flow. In laminar flow, there is subdivision. One is the plug flow and another is the parabolic flow. What is this plug flow? This is a laminar flow. This is most important. It is a flat, near identical flow profile. So everything, all the blood vessel will have the same velocity and it is represented by a narrow Doppler spectrum. And it occurs in initial systole in heart chambers and great arteries. What is parabolic flow? Here there is multiple broad range of velocity, and what is more important is the maximum velocity is at the axial center and low velocity is adjacent to the vessel wall. It occurs in diastole and abdominal aorta. To understand this laminar flow, it is like a sprint. If you see at the start, everybody has the same velocity. This is like the plug flow. Then you can see the axial center gets the maximum flow and the adjacent gets low flow. What was plug at the initial systole becomes parabolic flow at the diastole, but you get a uniform spectral image. That is your plug and parabolic flow. What is turbulent flow? Here there is an obstruction to the flow. Your blood flow becomes disorganized and there is wide range of velocity due to multidirectional current and vortex formation. To understand turbulent flow, this is like a finish of marathon. Everybody will have their own velocity. So you get multiple spectral images, and due to obstruction, some may not reach the destination also. Here you have an high spectral image, this is a mid spectral image, and this is a low velocity spectral image. So you will have multiple spectral image. This is the laminar and the turbulent flow. Now coming to the incident angle. The normal aortic blood flow velocity is about 2 meters per second. So if your probe is going to be parallel to that blood flow, you get the same velocity. That means if your incident angle is 0, you have the same velocity of 2 meters per second. Now you are going to hit the blood vessel at an angle of 10 degrees. The velocity which was around 2 meters per second now becomes 1.9 meters per second because your angle is around 10 degrees. Now if you are going to hit the vessel at an angle of 30 degrees, the velocity which was 2 meters per second has come to 1.7 meters per second. Now if you are going to hit an angle at 60, the velocity which was around 2 meters per second now is almost half. It is 1 meter per second. The more the angle you go, the velocity will be altered. You have to keep the incident angle as parallel to the blood vessel. An incident angle of 20 degrees is always allowed. Now coming to the velocity. What is velocity? It is the speed at which the blood flows. It is expressed in centimeter per second. And what we are going to do is calculate the volume, which is the amount of blood that flows. In another word, this is going to be your cardiac output, which is expressed in cubic meter per second. For converting this velocity into volume, we have to know what is called the velocity time integral, which is nothing but the cumulative distance or the stroke distance which the red cell have traveled with the systolic ejection phase. But you have to understand that the blood flow is not constant during cardiac cycle and it is pulsatile. So they have varied velocities. To overcome this, these velocities are sampled over one cardiac cycle and this sum of these velocities is integrated over time. Okay, this is the velocity time integral. And when this stroke distance or the TVI is multiplied with the area through which a blood flows, you get the stroke volume. And once the stroke volume is multiplied by the heart rate, you get the cardiac output. This is how a velocity is converted into volume. You have the area through which a blood flows. You calculate the stroke distance, that is the distance which the red blood cells travel. You get the volume. How you are going to do it? So this is the area through which the blood flows. You calculate the distance which is traveled. You calculate the area through which the blood flows. You require a cylinder-like structure to calculate it, where it can be done in the heart chambers. It is exactly at the LV outflow when the heart blood from the left ventricle go into the cylinder-like ascending aorta. So you calculate the distance from the LVOT through which the blood travels and you calculate the area across the LVOT. So where you are going to get the exact blood flow parallel to the aorta. You get in the deep transgastric long axis view. Here the left ventricle is there, the blood flows into the aorta. If you put the probe here, you can measure the velocity time integral. And this is the outflow track. You measure the diameter across the LV outflow track from which you can calculate the area. Here you can measure the LVOT diameter here, and here you can measure the velocity time integral from the LVOT to the aorta. So here the diameter is 1.8 centimeters. Your radius is going to be 0.9 and you place the cursor across the aortic valve, you get the velocity time integral which is around 25.8 centimeter. If you substitute the value, the diameter was around 1.8, so your radius is going to be 0.9. Your area is nothing but pi r squared. So you calculate the area and the velocity time integral was 25.8 centimeter. If you substitute the value, you get a stroke volume of around 66 and the cardiac output is stroke volume into the heart rate. So your cardiac output is roughly 5.2 liters. This is another great Indian mathematician who was the founder of equation. He not only discovered equation, he discovered zero, pi, trigonometry and motion of the solar system. And he was the founder of this simple equation, a plus b whole square is a squared plus b squared plus 2ab. Okay, this is the first mathematical equation which we learned in the 5th grade or 6th grade. What was very simple like this is Bernoulli complicated it. He made this simple equation into a complex Bernoulli's equation. He stated that the pressure drop across the narrow orifice depends upon three forces. One is convection acceleration, another is the flow acceleration, and third is the viscous acceleration. Here this rho is nothing but the density and V2 is the velocity across the area of interest and V1 is the velocity proximal to the area of interest. So how this complex Bernoulli's equation was simplified? Okay, what we are measuring is the peak flow and peak flow is very important for clinical measurement. But what is very important is during peak flow, this flow acceleration is non-existent. So this part of the equation can be removed. Coming to the next part. Viscosity becomes important factor if your orifice is less than 0.25 centimeter square. Normally with the orifice less than 0.25, the survival is not possible, and even if it is a very tight mitral or aortic stenosis, it is going to be less than, it can be more than 0.4. So your viscosity factor is also removed when your orifice is going to be greater than 0.2 centimeter square. So we have removed this part of the equation. And coming to the third part, for clinically significant lesion, the velocity across the stenosis is far greater than V1. The V1 is very negligible when compared to V2. So the V1 also can be removed by approximating, just we can have only V2. So we have removed V1 also. So what was a complex Bernoulli equation was simplified and rearranging the equation. The pressure drop is nothing but 4 times the square of the velocity across the area of interest. This is simple Bernoulli equation. So the pressure drop is 4 times the velocity square across the stenosis. So how we are going to utilize this to calculate the pressure? This is the right inflow outflow view where you look at the TR. Here the TR velocity is around 2.2 meter per second. So 4 times the velocity square to establish the gradient comes to around 27 millimeter of mercury. So you have converted the velocity to pressure gradient now. And if you look at the CVP and add this gradient to the CVP, you get the pulmonary artery systolic pressure. So this is how you convert this velocity into pressure gradient. Now coming to the last part, which is for calculating the valve area, which is the physics of continuity equation. Continuity equation is nothing but what goes in has to come out. It teaches an important principle in life. Here you can see Usain Bolt doing the traditional heart posture after winning the 100 meters. But in the next race, he loses to Galton. But what Galton did, he went and paid his respect to Usain Bolt. Why he does it? Because he know what Usain Bolt has done to sprint race. Here you can see he is paying the respect to Usain Bolt. This is what life is all about. When you give good, you get good. When you give bad, you get bad. When you share knowledge, you get knowledge. That is karma all about. What goes around will always come around. So be nice and share as much knowledge as you have. Here you can see the peak velocity across the aortic valve, which is around 3.6 meter per second. And this is the velocity across the LVOT, which is around 0.8 meter per second. And you measure the diameter across the LVOT, which is around 1.9. So the radius is going to be 0.95, and you calculate the area and velocity across LVOT, and you have the velocity across the aortic valve. If you substitute all the value, you get a aortic valve area of 0.8 centimeters squared. So to summarize, you should have a good knowledge about Doppler, Bernoulli and continuity equation. Doppler is used to calculate the volume, Bernoulli for the pressure and continuity for the area. You keep your incident angle to less than 20 degrees and avoid foreshortening and take measurement perfect places. If you take at a different places, your area might be altered. Average measurement is more important than a single measurement, and thorough knowledge of common view is very important to make the measurement more accurate. When you hear like this, you forget. When you see, you may remember, but unless with echocardiogram you do, you will never understand. Thank you.
Dr. Chirojit Mukherjee to give overall views on these three presentations. Chirojit.
Yeah, thank you and good morning from Heidelberg. I think it was a very excellent combination of ultrasound in practice. I feel, the presenters have highlighted that basically ultrasound can do away most of the invasive measurements which we do in routine ICU practice. And that's probably, we have come a long way from late 90s to early 2000s, and we are in 2020. So I think, as one of the speakers highlighted, stethoscope is a thing of the past, and ultrasound is going to be the future. I think it is already the future. It has, I don't remember any in the last couple of years where pulmonary artery catheter was electively put in the intraoperative setup. Unless you have a very bad ejection fraction, less than 20 or 25%. So coming to the first talk, I think Venugopal has really highlighted that, how all the intraoperative cannulations as well as, blocks can be very well done with ultrasound without the use of any other external source of imaging. And if you look by that, he has also highlighted that intraoperatively as well as postoperatively, you can reduce your measurements invisively and diagnose all the features which is presently required postoperatively, for example, pulmonary edema or anything kind of pneumothorax, which can be routinely done with ultrasound. And he has excellently demonstrated how blocks can be given. So I think it's an excellent lecture. Second, I think everybody knows that Deepak and his colleagues have done excellent work. And if you see the latest JCVA, John and his colleagues have actually said, I'll just cite something that Bode and colleagues are to be congratulated for highlighting that left atrial mechanics, as reflected by strain imaging, offer an important and valuable window for understanding assessing the left ventricular diastolic kinetics, including filling pressures and degree of dysfunction. So I think the message is very clear that, routinely you must be doing longitudinal strain and all those for ventricle, as well as you can apply it to LA mechanics. And with one single parameter, you can preoperatively as well as intraoperatively tell the surgeons about the left ventricular diastolic function as well as the filling pressures. And as they have highlighted, there are limitations. I think it's an excellent paper which they have produced. I have very clearly highlighted that, you know, there are limitations to the study. And intraoperatively, it may be a challenge to get a view of the LA using transesophageal echo, which they have demonstrated lovely views using a TTE. So I think, Deepak, you should carry on with this studies using probably TE in intraoperative use and try to get which may be challenging to get a view of the whole LA. And that can be a caveat to this study. But I think if you go by the transgastric method, then maybe you'll get a better view. Lastly, Ranjit, it's an excellent talk. I think I have learned that, you know, not only the history of ultrasound from way back in the where they was used in the submarines to the bats and late upgradation in the late 80s. And right now it's 6:30 in the morning in Germany, and the laws of karma is obviously, you have to remember for the rest of the life. And I feel the last slide is very important. You know, you understand the physics, you get the idea, you get teachers, but you can never understand ultrasound unless you do it yourself. So if you know that every course understands the knobology, every physics. So if you are good with physics and knobology, you'll be a very good echocardiographer. So with that, I hand it over to you, Dr. Vinayak.
Thanks, Chirojit. Very apt comments. And here are some quick questions to the first speaker, Dr. Venu. Is supraclavicular approach accepted for CVP measurement? That was probably Dr. Manoj wants to ask. So,
yeah, I mean, the only difference is that when we place it in the intrajugular vein, it is going straight, but the tip is lying in the same place, whether it is IJV or subclavian.
Okay.
And that bend, which is not very acute, I think should not cause any difference in the measurement of CVP, whether it is either subclavian or IJV.
Yeah, that's fine. The second question was the thickness of B lines and the spectrum of LV dysfunctional LV congestion. Does it represent? This was from Dr. Inamdar. So is there any correlation with the LV ejection fraction and B lines?
I mean, ejection fraction and B lines may not necessarily coexist. For example, if you have a high ejection fraction, as in diastolic dysfunction, and they are fluid overload, you get B lines. And if a patient who is low ejection fraction and very optimally controlled volume status may not have B lines. So combining together, we know whether the low ejection fraction is going to be increased extravascular lung water.
Okay. The last one was, will you take epicardial echo as point of care ultrasound for cardiac?
Absolutely, why not?
Okay.
I think because of lack of time, I didn't include that epicardial ultrasound here, but epicardial ultrasound is very well part of focus.
Excellent, thank you. And there are a few questions for Dr. Deepak. I have a question that when you do TE with the 3D, you can measure the LA volume, isn't it? So is that a next foreseeable thing that you can use this in practice? Because a couple of people are asking how to do it intraoperatively by TE.
Yes, we can definitely do it lot of volume measurements with 3D. But presently, the main limitation, as Dr. Mukherjee has already highlighted, is that inability to get a complete view of left atrium. And if we go transgastric, probably we may get a full LA borders. And by that, we can probably get an idea. But still, that has not been yet demonstrated. So if we get that, then definitely that is the way ahead. Thank you.
Okay. You're just behind the LA with the TEE. So I hope somebody will think about it and develop a technology that gives you a wide view of LA and measure the LA volume. I hope so. The technology will help us.
Yes, sir.
Yeah,
yes,
and
absolutely.
Do you think with grade 1 diastolic dysfunction, there is an increase in LA in your study?
Increase in LA? No, sir. We actually, out of the 60 patients that we studied, some 20-25 patients had got normal diastolic function. and another 15-20 patients had got grade 1. So we could find that there was significant reduction in LA strain right from grade 1 diastolic dysfunction, and it continued to reduce from grade 1 to grade 2 and grade 3 actually, and grade 3 had the lowest. So the diagram which I showed, that it has got a linear course across all the diastolic dysfunction grades. That's what we could also find. Thank you.
That's the biggest advantage, I think. It shows you
Yes.
that as the dysfunction goes on, the number goes down, and that's quite useful. Excellent. So
Yes,
any
sir.
other questions
Thank
from
you.
any of the chairpersons? Otherwise, I can ask all of us, and thank you all, and I can end this session.
I just want to ask one thing to Dr. Deepak.
Yes, sir.
Deepak, suppose you measure this in upkept patients in preoperative. What is, like, suppose it is grade 2 diastolic dysfunctions? What
Yes, sir.
What practicality you will implicate or apply for the management? How do you
Absolutely, sir.
Your findings with the clinical applications?
Absolutely, sir. That is what we were looking at. Like, before we get in the patient in theater, and if we can get it, and we know that the patient has got advanced diastolic dysfunction, like grade 2 or maybe grade 3. Not many patients usually come to theater in grade 3 because they are somehow optimized, but grade 2 is very common. So in these patients, we will definitely avoid fluid overload. Maybe early diuretic therapy will be definitely recommended. And in case of an hemodynamic instability in off-pump CABG patients, probably we may like to start with the inotropes or vasoconstrictor early on, rather than waiting for too long. In contrast, we will, in grade 1 diastolic dysfunction, we will try to avoid tachycardia. Basically, we'll try to improve the filling. And in those patients, they will be a little bit fluid tolerant. They are preload dependent. So we will probably try to give some IV fluids before we start on inotropes or vasoconstrictor.
So you will rely
Thank you,
upon
sir.
CVP. You will rely upon the CVP or center monitoring for grade 2, grade 3 patients?
No, sir, I will not definitely rely on a CVP single measurement, or even a trend for that matter. I will definitely not rely on CVP.
That's what my point is. Because of this so much high pressures, these are the not reliable way of measurements.
Yes, sir. Yes.
But in preoperative, immediately preoperative patients, you will do all the diuretics and everything? Because you are willing in the
yes, we will probably have a very low threshold for that. We will start very early on and proactively in these patients.
Right. Okay. I got to intervene here. Thank you a lot. The more important thing is see your patient preoperatively. I think that is a key factor. So I thank all the chairpersons and all the speakers for this magnificent session. I hope everybody has enjoyed. Thank you, Rajesh. Thank you, Sandeep.
Thank you.
Thank you all.